Imagine waking up in the middle of the night with your bed too red, swollen, painful, so much that the weight of the bed sheet becomes unbearable. That's an acute gout flare. So today in this lecture we are going to discuss the management of acute gout covering non-steroidal anti-inflammatory drugs, colchicine and corticosteroids, the decision-making strategies, the adverse effects. Before discussing the management of acute gout, it is crucial to understand the inflammatory mechanisms involved in gout. Gout is an inflammatory arthritis which is caused by the formation and deposition of uric acid crystals in the joints and soft tissue, causing damage to the joints. So before understanding or before knowing the management of acute gout, it is crucial to understand the inflammatory mechanisms that are involved in gout. It can occur as a result of hyperuricemia, there is increased uric acid production and decreased excretion of uric acid, and this causes elevation of plasma uric acid levels and deposition of urate crystals in the joints and synovial tissue. Now the deposition of uric acid crystals triggers an acute and chronic inflammatory response. As we can see in this figure, deposition of urate crystals in the joints causes activation of innate immune system, particularly the neutrophils and the macrophages. Within the macrophage, there is activation of NLRP3 inflammasome. This is a protein complex that plays an important role in initiation and development of inflammation. This causes release of cytokines such as interleukin-1, prostaglandins, lysosomal enzymes that causes exacerbation of inflammatory process and can cause damage to the joints and tissues. Now, the release of cytokines further activates, recruits the neutrophils to the site of crystal deposition. So, there is migration of neutrophils to the site of crystal deposition, and in an attempt to phagocytose those urate crystals, the neutrophils further exacerbates the inflammatory process. There is further release of inflammatory mediators, and this sets up a vicious cycle of inflammation. The joints are acutely inflamed, there is redness, pain, swelling in the joints, and because of persistent hyperuricemia, there is deposition of tophi in the joints. So what is tophi? These are uric acid crystals that are surrounded by inflammatory cells, and this leads to chronic inflammation. And because of chronic inflammation, there can be cartilage degradation, bone erosion, joint damage, deformities in the joint. Now, persistent hyperuricemia or elevated uric acid levels can lead to precipitation of urate crystals in the kidney tubules, and also there can be deposition of urate crystals in the interstitial tissue of the kidney. This leads to a decline in the renal function and leads to chronic kidney disease, chronic inflammation, fibrosis, decline in renal function, urate nephropathy, and chronic kidney disease. So, acute inflammation leads to chronic inflammation in presence of persistent hyperuricemia, and there can also be urate nephropathy affecting the kidney. So, the therapeutic goal is to provide symptomatic relief in acute gout and also to decrease the progression of the disease by decreasing the uric acid production and increasing the excretion of uric acid. So which are the drugs that are used for the management of acute gout? These are NSAIDs or non-steroidal anti-inflammatory drugs, colchicine and corticosteroids. Non-steroidal anti-inflammatory drugs or NSAIDs are the first-line agents for the management of acute gout. Given early in acute gout, it can produce rapid symptom relief and should be continued until 24 to 48 hours after symptom resolution and then tapered. NSAIDs act as anti-inflammatory agents by inhibiting cyclooxygenase enzyme, decreasing the prostaglandin synthesis and thus reducing the signs and symptoms of inflammation, pain, swelling and redness. The NSAIDs that are commonly used in acute gout are indomethacin, naproxen, piroxicam, diclofenac, ibuprofen and etoricoxib. Indomethacin is the most preferred and commonly used NSAID in acute gout. This is because of its strong anti-inflammatory property. Given at a dose of 50 mg thrice daily provides rapid symptom relief. Naproxen has a better GI safety profile. Piroxicam can be used. Etoricoxib is a selective COX-2 inhibitor. And because it is a selective inhibitor. It can be used in patients with high risk of gastric side effects. So in certain situations where NSAIDs are contraindicated, for example in peptic ulcer, renal disease, uncontrolled hypertension and heart failure, we can assess the use of colchicine. Now how does colchicine act? It binds to beta-tubulin, inhibiting polymerization and inhibiting microtubule formation, thus inhibiting cell division. So it inhibits mitosis by arresting the metaphase of cell division. It inhibits cell division. Now because of the inhibition of cell division, there is inhibition of neutrophil activation. So the chemotaxis of neutrophils to the site of inflammation is inhibited and the phagocytosis is blocked, and this inhibits the release of inflammatory mediators. Also there is inhibition of macrophages because of the inhibition of the protein complex, that is NLRP3 inflammasome, and this arrests the inflammation, this halts the inflammatory phase, and colchicine is the fastest acting drug in acute gout. Rapid symptom relief is achieved within 6 to 8 hours. However, complete resolution takes 2 to 4 days. Colchicine is not without side effects. So let's discuss the toxicity of colchicine. Do remember that colchicine has a narrow therapeutic index, which means that toxicity can easily occur in presence of renal and hepatic impairment. This is because colchicine is metabolized by the liver and excreted through the kidney. Also, drug-drug interaction is a possibility with colchicine when administered with other drugs that have action that are inhibitors of cytochrome P450. These are the enzymes that are responsible for metabolism of colchicine. So, inhibition of cytochrome P450 enzymes elevates the levels of colchicine, and this can lead to colchicine toxicity. Another property of colchicine is that it undergoes enterohepatic cycling, which means that it is metabolized by the liver, excreted in bile, reabsorbed from the intestine, and once again enters into the circulation. Also, it has high tissue binding affinity. Because of the high tissue binding affinity, the volume of distribution is very high, and this leads to prolonged effect of the drug. This extends the half-life of the drug because of its enterohepatic cycling and high tissue binding affinity, high volume of distribution. The most common and dose-dependent side effects of colchicine is the GI side effects. Because of its accumulation in the intestine, it has high tissue binding affinity, it accumulates in the intestine, and it inhibits mitosis, cell division. So cell turnover in the intestine is inhibited, and this leads to GI side effects such as nausea, vomiting, abdominal pain, diarrhea, abdominal cramps. So these are the common GI side effects that are observed with colchicine. Prolonged treatment with colchicine can cause myopathy and neuropathy. And in presence of overdose, death from colchicine overdose can occur, and it can result from muscular paralysis and respiratory failure. So death from muscular paralysis and respiratory failure in colchicine overdose. The next class of drugs that can be used in the management of acute gout are corticosteroids. Corticosteroids can be used when NSAIDs and colchicine are contraindicated. As we know that NSAIDs are contraindicated in peptic ulcer and renal disease, and colchicine has toxic side effects. So when the patient cannot tolerate NSAIDs or colchicine, corticosteroids can be used. Corticosteroids can also be used in severe gouty arthritis with multiple joint involvement. So multiple joint involvement, severe gouty arthritis, corticosteroids is the choice. These drugs act as strong anti-inflammatory agents because of the inhibition of phospholipase A2 enzyme, decreasing the synthesis of inflammatory mediators and relieving pain. Corticosteroids that can be used in acute gout are prednisolone, that is used orally, methylprednisolone, which can be injected directly into the joint, that is intra-articular administration. It can also be administered intravenously. Dexamethasone is used intravenously, particularly in seriously ill hospitalized patients. Triamcinolone can be administered intramuscularly and intra-articularly. Lastly, talking about the precautions that are necessary with the use of corticosteroids. Firstly, rule out septic arthritis before injecting the steroid into the joint cavity. Secondly, use caution in diabetic patients because steroids increases the risk of hyperglycemia when used long term. And thirdly, avoid prolonged use because it increases the risk of infection, adrenal suppression and osteoporosis. So these are some of the precautions that are necessary with the use of corticosteroids. So we have discussed the management of acute gout, covered the NSAIDs, colchicine, corticosteroids, the mechanisms involved, the toxicities, the side effects, the precautions. So if you find this video useful, please like, share, subscribe to this channel. Thank you for watching.